Greetings, everyone. Thank you for joining us in this symposium, which will explore on improving access to same-day CD4 testing from laboratory to community for advanced HIV disease. My name is Zibusiso Ndlovu. I'm a medical scientist and epidemiologist working for Doctors Without Borders, MSF. As we know, the world is off track from delivering on the shared commitment to end AIDS by the year 2030, and AIDS remains an emergency that we must not forget, even in our response to COVID-19. It is said that in the year 2020, we lost nearly 700,000 precious lives to AIDS-related deaths. Yet, we now know how to minimize this. A lot of progress has been made in research and development, and we now have different simplified and decentralizable diagnostic tools, including therapeutic options. Indeed, we now know better than ever how to beat AIDS. In this session, our distinguished guests will share with us their different experiences on the access to decentralizable CD4 diagnostics for advanced HIV disease. Our first speaker is Joseph. He is a professor at London School of Hygiene and Tropical Medicine. Joe is also a research associate at Harvard AIDS Institute in Botswana, among many other roles in the academia and industry. His session title is Laboratory Perspective, an evaluation of the VISITECT CD4 Advanced HIV Disease semi-quantitative same-day test. Joe will be followed by Augustina, who is a medical scientist working with the University of Lagos in Nigeria. Augustina's presentation will share a countrywide implementation perspective on the rollout of VISITECT. Solange will follow thereafter. Solange is the Executive Director of International Treatment Preparedness Coalition. Her talk is on access to diagnostic, the community perspective. And lastly, Ademola's talk will focus on the uptake of innovative health products. Ademola is a technical manager for strategic and resourcing for supplies. After all these presentations, we'll have a short panel discussions with all the speakers. Please post all your questions and comments in the Q&A. Over to you, Joe.
Thank you very much for inviting me to talk about our laboratory validation study of the VISITECT CD4 Advanced Disease test, which I am presenting on behalf of our team in Botswana. CD4 testing remains a key component of HIV care, primarily to enable identification of individuals with advanced HIV disease who require enhanced care and screening for opportunistic infections in order to prevent the significant morbidity and mortality seen in this patient group. Data from Botswana showed that even following the introduction of universal ART and removal of CD4-based ART initiation thresholds, a substantial proportion of individuals presenting to care, about 25%, still had CD4 counts below 200 cells. Further data from the large community-based Botswana Combination Prevention Project showed that very few of these individuals with advanced HIV disease would be identified by clinical screening, highlighting the critical need for CD4 testing, and that mortality and attrition from care following treatment initiation with individuals with advanced HIV disease was significantly higher than those without. The bottom panel shows mortality in one of our recent cryptococcal antigen screening studies, demonstrating the extremely high mortality in individuals with low CD4 counts and cryptococcal antigenemia, really emphasizing the importance of early recognition and intervention in these vulnerable individuals. Unfortunately, following the move to universal ART, we've seen a marked decline in the use of baseline CD4 testing in many settings in Africa, such as this study from Uganda, meaning the ability of clinicians to identify individuals with advanced HIV and offer appropriate screening and prophylactic interventions is severely compromised. Botswana, in common with most HIV prevalence settings, currently uses flow cytometry CD4 cell counting. Unfortunately, flow is accompanied with high maintenance costs, expensive reagents, and the requirement of skilled personnel, and it's not suited to remote or rural settings. There is a need for a low-cost CD4 test that can be performed by any healthcare worker and provide accurate CD4 count measurement that would help guide clinicians in appropriate patient care for those with advanced HIV disease. The VISITECT CD4 Advanced Disease assay is potentially such a test, an affordable, user-friendly, semi-quantitative diagnostic assay that was designed to be used at the point of care or primary healthcare level. The test is relatively simple to perform, requiring no instruments or complex reagents, and gives a result in approximately 40 minutes. With a straightforward visual readout categorizing samples either above or below 200 CD4 cells per microliter. Between November 2020 and April 2021, we performed a laboratory validation study of the VISITECT Advanced Disease assay in Botswana's main HIV reference laboratory. We restricted our study to samples from individuals who were having baseline CD4 tests and had no record of a previous CD4 count measurement in the electronic national HIV database. Samples from individuals under 5 years of age were excluded, as were samples that had been collected more than 24 hours prior to screening by the study team. Following routine CD4 testing using FACS, caliber, and aqueous flow cytometry instruments, patient samples were tested with VISITECT CD4 Advanced Disease kit by laboratory scientists blinded to the flow cytometry result. Testing was batched with a maximum of 6 tests performed at a time according to method 1 of the manufacturer's instructions. A visual read was conducted to determine if the sample had a CD4 count above or below 200 cells per microliter, and the results were recorded. For the last 4 months of the study, a second independent investigator conducted an additional visual read blinded to the results of both flow cytometry results and the initial visual read. We calculated sensitivity and specificity, negative and positive predictive values against the flow cytometry as a reference standard. To determine inter-rater reliability, we calculated percent agreement between the two readers using Cohen's kappa statistic. Of the 1,053 baseline CD4 samples we included in the final analysis, 62% or 654 were from women, and the median age of the cohort was 38 years old. Results from VISITECT and flow cytometry testing are shown here. 119 of the patients, 11.3% overall, receiving a baseline CD4 test had advanced HIV disease, a CD4 count below 200, based on the reference flow cytometry testing. The VISITECT test correctly identified 112 of these 119 samples as having a CD4 count below 200, giving a sensitivity of 94.1% compared to flow cytometry with an 85.9% specificity. The median CD4 count was 584 in the above range category and 223 in the below range category. In our cohort with a relatively low overall prevalence of advanced HIV disease, the positive predictive value of the VISITECT test for a CD4 count below 200 was 45.9%, with 112 of 244 samples classified as below range having a CD4 below 200. The negative predictive value was excellent at 99.1%, with 802 of 809 samples classified as above range having a CD4 greater than 200. Of the 132 samples with CD4 counts greater than 200 misclassified by the VISITECT test as being below range, the majority, 67%, had CD4 counts below 350. Inter-rater agreement was assessed through paired readings of 472 samples. Overall agreement was excellent, with 97.5% agreement between the two independent readers, giving a kappa statistic of 0.12. In conclusion, the VISITECT CD4 Advanced Disease assay had high sensitivity and good specificity when compared to flow cytometry in a laboratory validation study. Inter-rater reliability was excellent, with 97.5% agreement. Our findings are comparable to previous studies in India, Zimbabwe, and the UK. Thank you for listening, and very happy to take any questions.
Good day all. My name is Augustina Nwosu from the College of Medicine, University of Lagos. And I'll be sharing with you use of VISITECT CD4 LFA to diagnose advanced HIV disease. Our experience in Nigeria from 28 facilities. Lessons learned from lessons we also learned from the AHG phase implementation across our various sites. Background. Nigeria has the 4th highest HIV burden in the world and the 3rd highest in Africa, with our epicenter being in Benue State of Nigeria. What is the role of CD4 testing in the national HIV program? We all know that CD4 CD4 testing is the gateway to the AHD package of care, and it is critical in the identification of advanced HIV disease among people living with HIV. It's also very useful in determining the endpoint for secondary prophylaxis for common opportunistic infections that has been associated with AHD. Prior to 2021, what are the challenges that we experienced with the CD4 testing in Nigeria? We had a limited access of about 16%, and this was as a result of policies and priorities by the funders, with their focus being on viral load as the standard for treatment monitoring. Then there was also the drive for same-day ART initiation. We also experienced some operational challenges, which was a streamlined CD4 testing sites by the donors, which led to access problem by some other sites. And also we have equipment downtime and lack of effective planned preventive maintenance arrangements for some of these equipments. Even though flow cytometry was available in some sites, CD4 result turnaround time was still long due to operational challenges, which occurs at times in the course of sample collection, sample transport, processing at the lab, and the time it takes for the results to return back to the clinic. This invariably leads to delay in opportunistic infection management and ART initiation, and it takes at least 24 hours for results to return to the clinics. In 2020, there was a renewed drive for CD4 testing in Nigeria. Nigeria then went ahead to develop a package of care for AHD, following the WHO standards and guidelines on AHD and in-country assessment of AHD burden. In 2019, the national consensus was reached on the AHD package of care, and CD4 testing was recommended for all new patients before the ART initiation. And there was also the AHD implementation design, which led to site selections. In 2020, we had development of package of care and implementation tools. We had product adoption, which is our VISITECT CD4 Advanced Disease LFA. Then we had training of healthcare workers and implementing partners. In 2021, we then went ahead to procure the VISITECT CD4 Advanced Disease LFA and other AHD products. There was also the rollout in 28 sites, which accounted for 7.6% of all patients on ART. Currently, PEPFAR is supporting the country to scale up AHD package of care to over 2,000 facilities in Nigeria. A study was done from February to September 2021 to ascertain the impact of VISITECT CD4 Advanced Disease LFA on the AHD phased implementation in the 28 sites. And we documented 90% of the newly enrolled were staged with the WHO clinical staging. 83% of them received CD4 testing, which is a significant increase in access from our 16% to 83%. Then out of this 83% that was screened, greater than 50% of them were tested using the VISITECT CD4 Advanced Disease LFA. 42% of those tested had CD4 less than 200, which led to 80% of them being tested for TB LAMP, and 88% of them were tested for CRAG, respectively. Then a study was done to carry out a comparison of VISITECT CD4 Advanced Disease LFA and flow cytometry. 10 of the 28 facilities conducted both the VISITECT CD4 Advanced Disease LFA and flow cytometric tests. And this was done on 603 new patients from February to July 2021. Out of 307, 268 out of these 307 CD4 samples analyzed to be less than or below reference with the VISITECT CD4 Advanced Disease LFA were also correctly identified with the flow cytometry. while 277 out of the 296 CD4 samples that had values greater than 200 or above reference that were analyzed with the VISITECT CD4 Advanced Disease LFA were also correctly identified with the flow cytometry. This invariably gives us a positive predictive value of 93.6% and a negative predictive value of 87.3%, respectively, for the VISITECT CD4 Advanced Disease LFA. The VISITECT CD4 Advanced Disease LFA can correctly identify patients with AHD based on findings from our experience in Nigeria. So let's look at the benefits of using VISITECT CD4 Advanced Disease LFA in the National AHD program. And the question we needed to ask was CD4 able to fill the CD4 testing gap in Nigeria? The answer is yes. And in a survey that was carried out among 43 healthcare workers in the 28 sites about VISITECT CD4 Advanced Disease LFA use, 81% of them agreed that it is a simple test that can be conducted by healthcare workers. 88% of them agreed that sites with low to medium client volumes will benefit immensely from using the CD4 LFA. While 25% of them agree that the testing is best suited for use at the point of screening. That's where we do our HIV screening when the patient comes in. 71% stated that it's preferable that it's done in the laboratory, while 4% suggested that it should be done in the consulting rooms while the doctor is consulting with the patient. Generally, experiments have shown that VISITECT CD4 Advanced Disease LFA test is a same-day point of care test that is easy to use. It does not require skilled personnel to perform, and it's easy to read. What are some of the additional lessons that we learned from this implementation phase? Updates from implementation today shows average turnaround time for CD4 was improved from 24 hours compared to the 2 days to 1 week when we're using the old methods. VISITECT CD4 Advanced Disease LFA also have the potential to support AHD management in community settings where they have access to limited resources. And some of the limitations were that the shelf life is 12 months. As a result of this, it requires efficient supply planning so that we don't end up with having stockouts. Then the testing time of 42 minutes was also raised by some of the healthcare workers. You know that it's especially when patients are coming in at all times, that 42 minutes is quite long for these patients. Then test results could be subjective, especially for borderline results. In conclusion, AHD implementation has improved quality of care for people living with HIV from our experience in Nigeria. VISITECT CD4 Advanced Disease LFA has demonstrated the possibility of reaching 100% CD4 access with limited resources. The country has commenced scale-up of VISITECT CD4 Advanced Disease LFA test and AHD package of care to all other ART sites. We have over 2,000 sites, and VISITECT CD4 Advanced Disease LFA will account for 60% of all CD4 testing in all the sites. My acknowledgement goes to the AHD Working Group, NASCAP, CHI, PEPFAR, and Global Fund for their support. Thank you.
Hi, everyone. Good day. My name is Solange Baptiste. I'm the Executive Director at ITPC, or the International Treatment Preparedness Coalition. And I'm here to talk a bit about the community perspective to access to diagnostics. I think we're all aware of the persistently high levels of death due to HIV. In 2020 alone, we were close to 700,000 people dying. Our 2030 targets having that be less than 400,000, as you see in the orange circle, is met with the stark reality that in many countries, 30% or more of new patients, new HIV patients, still present with advanced HIV disease, or shall we just call it what it is, AIDS. Making this target and this goal of saving lives very challenging. And so this brings us to the community experience with AIDS and attitudes towards seeking healthcare. And I wanted to just kind of break it down in general terms, just plain English. There's a pervasive notion that unless you are feeling unwell or ill, you do not engage with the public health system. So you have then categories of recipients of care, patients and people unwell and in hospital and then discharged with outpatient linkage, with, often in a very fragile condition, with many confusing instructions and follow-up plans, which can be problematic and tricky. And then you can be unwell, but in home in a non-clinical setting, meaning that you don't go to the hospital for various reasons, right? Ranging from your past experiences, your culture, your family, personal preference, socioeconomic, whatever it may be, but you are unwell and at home, you're not in a clinical site. And then those who are well, those who feel okay, but have advanced HIV disease by the clinical definition, right? Not being virally suppressed. So what we call sort of the walking well, they feel well enough, but they are at risk for serious health problems. And so that brings us to looking at where and how this really plays out in real life. When people living with HIV present late, they discontinue treatment and they're unable to access effective ART, they may develop AHD. People with AHD are at high risk of opportunistic infections, as we all know. And this just brings us to this sort of realization that none of this is really linear in path, right? There are periods of engagement and re-engagement in the cycle of HIV cascade that we often talk about. And our goal here is to minimize the frequency and the duration of periods of disengagement, as we see in this graphic on the right. So what do people seeking healthcare think about is where I went next in the flow of thinking here. And I thought I'd bring these measurements up and ask you, if we were live or in person, unfortunately we're virtual, what do these measurements represent? These 19 hours and 45 kilometers. And they represent how long a person is willing to wait and how far a person is willing to travel in order to see a, let's say, nice or kind provider of healthcare versus a rude one. And this was taken out of understanding preferences for HIV care and treatment in Zambia, evidence from a discrete choice experiment among patients who had been lost to follow-up. And so it just really brings and drives home the point that recipients of care, and if you think about yourself, it's the same. What do you want when you're seeking healthcare? You first want to find quality services close enough to where you are. And you want the option to do the right test at the right time so you can get the result quickly, so that you can get the appropriate treatment and be able to get the care and move on with your life. And it's the same as we have studied and understood. So generally what we're looking for is early diagnosis coupled with access to optimal treatment. But this is not an issue of science, but an issue of access. And why we're struggling on the early diagnosis is something that we need to unpack. There are existing life-saving interventions that can be implemented now. However, we still find ourselves in this problem of unnecessary deaths. And we know that health is still determined by market forces. That's the system we seem to be living in, and it does not work. For recipients of care, we still have barriers such as prohibitive pricing, poor availability, low recipient of care demand, provider demand for specific diagnostics and tests. And that is preventing these existing life-saving interventions from coming out to save lives. Whether it's CD4 testing or routine CRAG screening or community support models or effective and optimal treatment, which we can list. This is where the context and the framework within which we're living. I thought it would be interesting to think about this costly no-do gap. We know what should happen, but it doesn't actually happen in practice. And if we look here at the screening of preemptive therapy for cryptococcal meningitis, as an example, in people with AHD, you know what should happen, you know, all the way from CD4 count to diagnose, all the way to weekly home visits. And what happens in practice is access is not universally available. So if you could run down the list, you'll see none of them are actually a problem of clinical interventions or science. We have low access, not available, incompletely implemented, poor screening, not carried out, unavailable, poor market, market failure, and poor community support. And this, I thought it was an interesting quotation. It talks about the vicious cycle of perceived low demand, limiting manufacturer interest in specific product markets. And so, you know, it brings us to this question of how did we get here? And, you know, we started off with test and treat, making targets really the focus, chasing, setting, reaching these targets, and primarily applying our minds and models to DSD, differentiated service delivery for stable patients. And, you know, CD4 and AHD or AIDS ranked lower and lower on the priority list in all of the diagnostics and treatments that go along with it. And so here we end up in a state of avoidable deaths. So unlike other diseases, the problem is not what to do, but how to do it is the issue. And so we have this costly no-do gap. So the key message I would like to send home is that technology, these innovations that we come up with, whether it be CD4, same day, or whatever it is, should serve the need of the people, not the volumes in the market. Donors should invest proportionately in improving disease screening, preemptive management, and treatment to address AIDS-related deaths, right? Same-day results for CD4 testing is urgently needed. How we now have the evidence to show that these tests can work, but they can be, and that they can be cost-effective, but there is no proper scale-up. There's an urgent need for investment from governments and donors. We must optimize diagnostic networks across diseases and not just focus on a lab or a specific lab or single disease. Donors need to coordinate across diseases and ensure conditional funding for technologies and innovations that we know work. And an innovation must be equally focused on ARVs and diagnostics, right? I think it's very scary to think that in 2017, which is a while now, WHO HIV drug resistance reports that shows that 6 of the 11 countries surveyed, over 10% of the people starting ART had a strain of HIV that was resistant to some of the most widely used HIV medicines. So in the context of AHD or AIDS and avertible deaths due to cryptococcal meningitis, activists really call for the same day, the scale up of same day CD4 testing where needed. Clinical teams need to include community healthcare workers that are not just living off of air and good works, but actually are trained and paid. We want to see robust and urgent application of DSD principles to improve services for people with and at risk of AIDS. And we want to also see resourcing, education, demand creation, monitoring, research, and advocacy for AIDS, advanced HIV disease, and cryptococcal meningitis. Thank you very much.
Hi, everyone. My name is Ademola, Osigbesan, Technical Manager, Strategic Sourcing and Supply at Unitaid, and I'll be presenting at this satellite session. Very excited to be doing so on the accelerated uptake of innovative health products, showcasing the Unitaid Chai early market access vehicle done in partnership with Omega Diagnostics. My presentation would follow a very simple outline, starting with the background and moving on to Unitaid's focus, a deep dive on the early market access vehicle, and summary of progress and lessons learned, as well as future opportunities. Just a quick overview of the work Unitaid has been doing in this space of advanced HIV disease in partnership with a number of global partners like PEPFAR, the Global Fund, MSF, and other members of the steering committee that we have. We've collaborated extensively over the past 2 to 3 years, and Unitaid's contribution, beyond supporting the CHI projects on early introduction and early introduction work in countries, we've also done a lot in terms of facilitating access to the QTIB product, rifampicin-based formulations, expanding supply capacity and price reduction for 5FC, working on liposomal amphotericin B also through a partnership and a price agreement with Gilead. And to the major thing we're discussing today, the price reduction, catalytic introduction, and early market vehicle for VISITECT CD4 Advanced Disease test. So one thing we all know, and that has been discussed a lot today, is the fact that, the semi-quantitative CD4 test offers an opportunity to expand the use of CD4 in early detection and management of AHD. We see so much value in this. Hence, Unitaid in 2020 approached Omega Diagnostics and pushed for an improved price agreement on this product that allows the product to be sold at little below $4 in over 130 countries within the LMIC bracket. And this was the opening of an opportunity for work in catalytic introduction, and as we're discussing today, the early market access vehicle. And just a quick description of this vehicle. Basically, it is a procurement commitment by Unitaid to provide 500,000 VISITECT Advanced Disease tests globally in countries, in high burden HIV countries. And this is a commitment to procure and is meant to be based on demand across countries, open to all partners and governments that work to support HIV programs. We do want this to be across as many countries as possible. So we've pegged number of tests per country to 50,000 tests. So we do not intend to give more than 50,000 tests to any country. And of course, we do also expect simplicity in operations. So it's just about four implementing partners at the maximum. CHA is the coordinating secretariat, and the applications for the EMAV opened in April 2020, and it's still on till December 2021. As of today, it's been quite exciting to see that over 360,000 tests have been ordered as of December 1st. And this is across 17 countries, as you would see on the map, and multiple partners have been supporting this. We can see partners like MSF are very active in supporting this expansion, ECPAF, and other partners like ITEC and Lighthouse. What we see is that a number of these countries are already sharing very great experiences with the product, and this has spawned many other applications coming that we do expect would be delivered in the next 6 months. The other exciting bit about this is that the 360,000 is a combination of products and orders from the EMAV, but also the fact that we're beginning to see orders coming in from scale-up partners like PEPFAR and the Global Fund. So as you would see in this graph, we started in Q2 2020 in anticipation of WHO pre-qualification that happened in Q3 2020, and we've seen a steady growth, and we've also seen very good adoption and orders coming in from countries which are supported by the Global Fund and PEPFAR. We see this momentum is building, and we're super excited about this. Safe to say, my last point is that, yes, the EMAV has been a success, but we're still open for the next couple of weeks, hoping to see more applications come in. And just to say that any organization or government that indicates interest in the EMAV within the next couple of weeks will be given expedited attention, and to ensure that you meet the December 31st timeline. Thank you very much. It's been exciting working with the Clinton Health Access Initiative and Omega Diagnostics on this initiative. Open to questions thereafter. Thank you.
1 in 3 people living with HIV risk contracting potentially deadly opportunistic infections. In sub-Saharan Africa, this number is closer to 1 in 2. Every year, 700,000 people die of largely preventable deaths from HIV. CD4 cells, also known as T cells, are white blood cells that fight infections. HIV attacks and destroys CD4 cells, so people living with HIV are more prone to infections. CD4 testing is the best way to identify advanced HIV disease and prevent deaths. The World Health Organization defines advanced HIV disease as having less than 200 CD4 cells per cubic millimeter.
For patients with advanced HIV disease, delay between testing and treatment can be fatal. For this, we must increase effort to detect this disease faster through rapid decentralized CD4 testing.
Omega's VISITECT CD4 Advanced Disease is a game changer. VISITECT CD4 Advanced Disease allows health workers to make decisions faster. It provides same-day CD4 testing and so reduces loss of follow-up.
Omega Diagnostics product is a disposable instrument-free test approved by the World Health Organization. In only 40 minutes, it can detect whether people have a CD4 count below 200 cells per cubic millimeter. In 2020, Unitaid, the Clinton Health Access Initiative, and Omega Diagnostics partnered to boost CD4 testing uptake. This innovative pricing agreement increased people living with HIV's access to tests in 130 countries. It helped secure CD4 tests for $3.98 per unit, the lowest price in the world for such tests. Through its early market access vehicle, Unitaid is donating 500,000 CD4 tests to high-burden countries. Funded by Unitaid, the early market access vehicle is being leveraged by health actors in 17 countries.
The VISITECT rapid test enables us to detect advanced HIV disease faster and provide better care. If this test is more widely available, people won't have to visit health facilities as often. For instance, in light of COVID-19, this represents a major advantage as it will help to curb the spread of the disease.
To significantly reduce deaths and illness from HIV/AIDS and accelerate an end to the epidemic, we must embrace innovative health technologies such as VISITECT. The early market access vehicle positioning this test for scale at the point of care is a clear example of how Unitaid is driving innovation in global health. It's only through initiatives and partnerships such as these that we can best place ourselves to respond and overcome the major epidemics and pandemic the world is facing today.
This work has been made possible through the generous support of Unitaid and partnerships with Omega Diagnostics, the Clinton Health Access Initiative, the Ministries of Health of Nigeria, Uganda, and Zimbabwe, as well as implementing partners.
Thank you very much to all our speakers for the great presentations. We will do a quick panel discussion before opening for questions from the audience. I'll start with you, Joseph. It's exciting to see these good diagnostic performance results for this disposable point of care test from Botswana. As you mentioned, your study findings are similar to some in the region and beyond, and I suppose there are probably many more ongoing studies or planned studies on VISITECT either in the region or globally. And we know this can affect product implementations. We have seen urine tubulum delayed by ongoing studies from different countries or regions. So my question is, from your vast experience, how can we learn from these past experiences and improve collaborations among countries to share data quickly or among PIs, which could ultimately quicken the implementation of such a crucial product, especially as well with just 8 years towards the 2030 UNAIDS goals? Thanks.
Yeah, well, thanks. It's a very good question, and I think a frustration for many of us working in the field that getting products registered, and it's not just diagnostics, actually the same applies to essential medications, often requires individual studies in individual countries. I think as researchers, there's something that we can do in terms of ensuring that we collaborate closely with colleagues across the region, that when we conduct studies, we make them multi-country studies. And so in a single study, we can generate data from numerous countries, which can hopefully help with the regulatory processes in those countries. But I think really we need to go beyond just the research and talk to the regulators and the countries and try and harmonize the regulation process for diagnostics. And I know that there's been a lot of work going on, some of it supported by Unitaid and with the African Union, to try and set up harmonized regulatory processes for diagnostics. But I think, unfortunately, you know, as clinicians on the ground, we're not yet seeing the fruits of those labors, and that needs to continue. There needs to be ongoing work to work with regulators, get harmonization and hopefully end up in a system where we can have a single or maybe just a few studies done, and that other countries will accept data generated by other countries in the region rather than needing individual studies themselves, because it makes everything very slow.
Thanks, Joe. We look forward to such multi-country collaboration. Thank you very much. Moving on to Augustina, thank you very much for sharing your experiences from Nigeria. And it's quite commendable, those efforts in implementing VISITECT widely. The question that probably I would like to ask you is the kind of demand creation or the sensitization that was done in Nigeria to clinicians or to patients or even to the community about this point of care CD4 test. What was done? Were there any explicit policies that were shared to improve the uptake to over nearly 28 facilities, as you say? Thanks.
Yes, thank you very much. In Nigeria, we started with training of facilities. So we started selection of, we all worked together, and there was the sensitization and the training that was done. That was sometime October last year. Then early this year, we went as far as including the sites. In fact, recently, that was October this year, we were able to do sections that we did for both, for all the healthcare workers. One was held in Abuja, one was held in, we had 2 centers in the north.
We seem to be losing you,
The north central. Okay, can you hear me?
Yes. Do you mind switching off your video maybe to improve the connectivity? We can hear you. Go ahead. Switch off your video, please. Thanks. And go ahead.
Okay. So we went as far as going to the regional training, not. You said? Can you hear me now? Hello,
yes,
can you hear me?
Augustina. Go ahead, please.
Okay, so we went to the east, we went to Akwa Ibom, and we went to Ibadan. We decentralized the training to the regions where we sensitized the healthcare workers. We brought the pharmacists, we brought in the doctors, we brought in the nurses, we brought in the lab staff, we brought in all the other healthcare workers, and we sensitized them, and we carried out training. And as I speak to you now, there's a scale down of training to going down to the local governments and the local communities, and on the sensitization work for the implementation of the use of the VISITECT LSA product.
Thank you, Augustina. I would like to also urge the delegates, the audience, to post any questions into the chat whilst we continue with the panel discussion. Moving to Solange, in your excellent presentation, Solange, you rightfully mentioned that CD4 testing and the general advanced HIV management package of care are ranked lower in priority within many countries. And from the community perspective, what else do you think still needs to be done to ensure that we can change this within the remaining 8 years towards the 2030 UNAIDS goals?
Hi, thanks, Dee. I think there are many things from a community perspective that are still lacking and still needs to be addressed. I think often when the community of practice thinks about how to engage recipients of care, we think about demand creation. So tell people about it and let them ask for it. And I think we need to start thinking a bit beyond that, although there is a definite value that communities can bring patients, recipients of care, general people living with HIV community can say, yes, this is important. This is how we can detect things early and prevent advanced HIV disease. But there is some more work that can be done around, I would say, community monitoring and the ability to be able to say, well, what's actually happening? Because often there's a policy and there's a gap in what actually happens on the ground and in reality, especially at local, at the subnational level, at sites. So there may be one policy, there may be one price, there may be one thing that should be happening unified at a national level. But what happens as the reality for out-of-pocket payments or stockouts or costs that are actually incurred at the clinic and site level, which are actually a lot of nuance that communities can pick up if they're engaged in proper monitoring at the local level. I think there are other things that people touched on, but I think the demand generation and the monitoring can actually help us to move in the right direction to ensure wider access. Thanks.
Thanks, Solange. And lastly to Ademola, thanks for your presentation. And you mentioned that the EMAV applications will be active from April 2020 to December 2021. Is there an extension for this deadline? And I mean, my worry, of course, is again around the issues of the impact of this EMAV in terms of the pricing. Is the EMAV going to help in any way also in terms of market enterprise after this framework is over? Thanks for that.
Thank you very much, C. Actually, the initial deadline was October. So what we have now as December is an extended timeline, and it's not likely to be extended beyond that, unfortunately. But what we have is an intensified period between now and the end of the year. So any applications that come in or any indications of interest that come in will be given utmost support to be able to cross the finish line before December. I see John on the panel also. So I believe Omega is committed to maintaining the $3.98 price beyond the EMAV, because the agreement back then was that once we're able to get the level of scale up that we're seeing now, the volumes will be good enough to maintain the price. Whether or not Omega would go below that price is another question we may ask them at a later time. But so far, so good. I think it's been a good experience. Countries are taking this up. The price is not prohibitive as it stands today, and we look forward to getting to a point where the volumes will be huge enough for Omega to consider further reductions. Over.
Thank you for your answer. And I suppose, judging from your presentation, many countries are now implementing. We hope that the volumes will be high enough. I'm seeing this question in the Q&A for Solange. I'm going to read it for you, Solange. It comes from Moby. Moby says that. It looks like.
Sorry, while you were speaking, I was actually typing the answer.
All right.
I can say it out if you want, as you like. Yeah.
Well, I think probably you've answered it well. Maybe go ahead and just say it in a minute. We're running out of time.
Sure. It was just a question about what did it mean to have conditional funding on this case, and I was just saying that really need to make sure that the gap analysis and where the need is at the country level matches what donors, multilateral donors, and how they can actually influence the market, the access, the price, and the volumes. And they have a lot of power in that sense. And the link with governments and domestic resource mobilization, there's a complex interplay there that I think the conditions can actually help to drive access. Thanks.
Okay. I see we don't have any questions at the moment. We still have time. Maybe I can just come back and ask another question if possible to Augustina. Augustina, just to know from Nigeria, which kind of healthcare workers in these 28 facilities were responsible for using the VISITECT? And why I'm asking this question, maybe the audience may be interested, because we know with the continual emergence of these simplified point of care tests, there is a need to think around how to re-engineer your human resources, because we know frontline healthcare workers in the near future or even now, they are probably overwhelmed with many activities, and just dumping these tools and assuming that the frontline healthcare workers, your nurses, your clinicians will use these tests, it's most likely not going to have maximal impact on disease testing. So maybe just tell us a little bit, which healthcare workers were responsible? Was there task shifting? Was it the lab? Was it the nurses? What was there? Just in a quick response. Thanks.
Okay, so it's a mix-up of healthcare workers. We had technicians, we had nurses, we had phlebotomists. And mainly the phlebotomy, because at the point where they are doing the screening for the patient, once the patient is positive for HIV, so immediately they go ahead to screen the patient with the visitors to be able to ascertain whether the patient falls into the ASD group or not. So that's what we are doing as a country. So the people at the phlebotomy unit are the ones that we are using right now to mainly for the training, to carry out this CD4 testing. But we have other healthcare workers involved in the training, so that if help is needed, then we can always also fall back to the nurses, the clinicians, some of the doctors, and the technicians.
Yep, it does make a lot of sense. Thank you for that. I think one massive point we are getting from this presentation is that this point of care test, the VISITECT, absolutely can have massive impact, especially at point of care, because we know that's where patients present initially. I think just to conclude, if there are any other question, this session, basically, I'm hoping for me, I mean for everyone, just like for me, it is more or less emphasize how point of care testing is an area of high priority for investments, especially with new tools like we have with VISITECT, and also there's new treatments. And a combination of these can enable decentralization of health services. So we're in an era where the long turnaround time of centralized testing is slowly becoming unacceptable. And I'm hoping that the audience that was available here did get this feeling from this session, from the first session that highlighted the good diagnostic performance of the new point of care test. Even the experience from Nigeria, it's quite good to see how the implementation is happening in these facilities. I'll open again in case there's another question or any last thoughts from the panelists. I can probably just give any 2 minutes. I'm not sure also from the team that's joining from Omega, in case they have anything just to add on like that. We have about 2 minutes before we close the session. Thank you very much for everyone, especially to our amazing panelists and the good audience. I think I'll conclude this session, and goodbye to everyone, and good to have you around. Take care.